Now we are having a debate. It's on intermittent fasting in CKD and diabetes. So I would like to invite the speaker Sanjeev Nair sir, Senior Consultant in MIOT International, Chennai. I would also like to invite Nagraj Naik sir, Associate Professor of Nephrology in SDM College of Medical Sciences and Hospital. Now, I'm delighted to invite the chairpersons for this session. Dr. Dhanalakshmi Madam, Professor and HOD, Department of Nephrology, ESIC Super Speciality Hospital, Hyderabad. Then I would like to invite Dr. Anupama Kaul Ma'am, Professor, Department of Nephrology, SGPGI, Lucknow. Going on to the next chairperson, Dr. Santosh Kumar sir, Senior Consultant Nephrologist, Kamineni Hospital, Hyderabad.
Good morning, everybody. Going on to the next session, I'd like to introduce Dr. Sanjeev Nair. He's a Senior Consultant and Transplant Physician at MIOT International, Chennai. He is for the pro-intermittent fasting. He's going to advocate, and let's hear what points he has.
Thank you, ma'am. Good morning, everyone, and thank you to the organizers for the invite and for the hospitality. I'm here to speak for the proposition intermittent fasting in diabetes and DKD is a friend. I've added my own rhetorical question, is this really still a debate? I think the organizers have shown a sense of humor by asking the more overweight speaker to speak for fasting. But this is not really a talk about fasting versus not fasting, but about whether we as nephrologists are willing to recognize a legitimate clinical tool for which there exists a ton of evidence. Hippocrates said, to eat when you're sick is to feed your illness. Now, I am not saying we should go back to Hippocratic era practice. I'm simply asking if modern medicine is willing to look at modern data about something that even the ancients were aware of. These are my three central arguments. First, intermittent fasting is not one intervention. It is a family of interventions and can be individualized to the patient as per need. Second, the ADA Standards of Care 2004 has already moved intermittent fasting and time-restricted eating into serious clinical conversation as practical tools for weight loss and glucose management. Third, nephrologists already practice fasting medicine every Ramadan when we assess, stratify, and counsel and adjust medications and monitor CKD patients who choose to fast. So for our specialty, this is not theory, this is lived clinical reality. As our nation's most loud anchor would ask, the nation really wants to know if fasting is anti-kidney. Jokes apart, we now face a barrage of online information from clueless wellness influencers to supremely confident but conflicted and experts to confused doctors and ideologues who have their own take about all things dietary. But for us as clinicians, the important thing is to understand the evidence and to take informed decisions. So intermittent fasting is an umbrella term. It includes time-restricted eating, such as 16:8, 18:6, and 20:4, of which the smaller numbers are all the restricted eating window, and alternate day fasting, or a 5:2 approach, where the patient eats normally for 5 days and has a severe calorie restriction of less than 500 calories for 2 days a week. These can be adjusted according to the patient's clinical requirement, lived reality, and disease burden. These are all not physiologically identical, behaviorally identical, or clinically interchangeable. So whenever someone says fasting is dangerous, we must ask which pattern of fasting, in which patient, on what medications, and with what monitoring. Moving on, we know from animal studies that fasting positively impacts diabetic nephropathy progression through multiple pathways. IF maintains mitochondrial homeostasis, improves ketone body production, promotes autophagy, and thereby delays diabetic nephropathy progression. In simple terms, that means fasting shifts the body from constant storage mode to repair mode, and this metabolic shift reduces cellular stress. Now, fasting is not an imposed foreign intervention. It is an extension of built-in physiology. We know from our first-year guidance that the human body has a fed state and a post-absorptive state. Even normally, the post-absorptive state is 4 to 12 hours. Now, when fasting extends, the body sequentially moves from glycogen depletion to gluconeogenesis and eventually to ketogenesis. All of these processes are normal, which is to say that our human body is built for metabolic flexibility, and that intermittent fasting is not some alien metabolic program, but it leverages tools that the body already has. Now, my opponent will paint fasting as automatically pathological, when in reality, the underlying physiology is normal, adaptive, and ancient. This is why I say this is barely a debate now. We have ADA guideline recognition. We have multiple RCTs and systematic reviews, all of which show that glycemia improves, insulin resistance improves, weight management is easier, and cardiometabolic parameters improve. We also have multiple studies in both animals and humans which show, which are biologically coherent and which show mechanistic benefit in DKD-CKD pathophysiology, which shows improvement in lipid metabolism, mitochondrial function, autophagy, and inflammation. And then we have validation from Ramadan. When all of these converge together and point in the same direction, the burden of the proof shifts. The ADA standards of care place intermittent fasting and time-restricted eating as a practical tool for management of weight and glucose management, not a fad. It also makes three important points which are relevant to this debate. One, meal timing matters, and the plan can be adjusted to the individual patient's eating pattern. Two, earlier eating windows can enhance metabolic benefits. And three, safety is dependent on monitoring, especially in patients who are on insulin and secretagogues. So the correct takeaway is not that ADA has endorsed unauthorized fasting for everybody. It is that IF is now accepted enough to be considered mainstream diabetes care, provided it is individualized and supervised. Okay, we'll move now from theory to measurable outcomes. There is a ton of evidence, both RCT and meta-analysis, which show benefit for intermittent fasting in diabetes. Due to time limitations, I cannot go through all of it, so I've picked two meta-analysis. This one has 10 RCT data which it has compiled, and we can see that there is improvement in decreased fasting glucose, decreased HbA1c and mean glucose, and improved time in range for the glucose. These are not miraculous numbers, but these are real, consistent, and clinically useful. These are the kind of numbers that we would consider meaningful when we talk about lifestyle modifications to our patients. If you move to the medication story, we can see that patients who have been on intermittent fasting were able to reduce their insulin dosage. Some stopped some of their hypoglycemic medicines and adjust those medicines. This is not an argument against intermittent fasting. This is an argument for supervision of medications and bringing it down. If we move on to insulin resistance and adiposity, we see that fasting insulin, HOMA-IR, fasting glucose, and insulin sensitivity, weight, BMI, waist circumference, body fat percentage, all show improvements. In practical terms, IF does not simply reduce blood glucose levels, it improves the insulin resistance phenotype. This is relevant to us as nephrologists because DKD is not merely driven by glucose levels, it is driven by the entire cardiometabolic syndrome, insulin resistance, adiposity, inflammation, ectopic fat deposition, and hypertension. This brings us to metrics that are closer to nephrologists. We care about blood pressure, lipid profile, inflammation, and oxidative stress because these parameters are relevant for long-term renal and cardiovascular risk. Here we can see a modest but meaningful reduction in systolic BP, diastolic BP, total cholesterol, and triglycerides. The inflammatory and oxidative stress signals are also moving again in the right direction. None of this means that fasting is a magic bullet, but it does mean that the intervention is improving multiple risk factors and that these matter deeply to patients who are DKD or CKD. So why should a patient care about intermittent fasting, patient with DKD? This is because IF appears to intersect along multiple pathways that are relevant to diabetic kidney disease. They reduce ectopic lipid deposition in the kidneys, improve mitochondrial homeostasis, enhance autophagy, decrease oxidative stress, and modulate inflammation along with improved hypertension and metabolic control. Now, these are not random effects. These are what we know to be in line with the DKD pathophysiology. So, even if the hard renal outcomes are not yet definitive, what becomes apparent is that the biology is difficult to dismiss as unconvincing. This is probably the most relevant slide for us as nephrologists. I am not claiming that the renal outcome evidence is as robust for intermittent fasting as it was for diabetes control and glycemia. It is not, but it is not absent either. We can see that there are kidney relevant signals. The creatinine stabilizes in some patients. There is a possible eGFR benefit in selected cohorts. There is a reduction in proteinuria and albuminuria in some studies, and consistent improvements in blood pressure, HbA1c, and weight. This is not to say that the kidney data is final. I am simply saying that the data is encouraging enough for us to justify selective clinical use rather than a blanket dismissal. This is one of the most important slides for my talk. Every year during Ramadan, nephrologists assist CKD patients who want to fast. What do? We evaluate CKD stage, proteinuria, comorbidities, review medications for hypoglycemia risk and dehydration risk, and stratify the patients. We adjust insulin and diuretics. We plan their monitoring and we tell them when to stop. What does this mean? This means that our specialty has already accepted the core principle. Fasting can be compatible with kidney care in selected patients, and this is for a completely dry fasting state. This debate is happening in Hyderabad, where I expect this is the norm. So this is not an intellectual exercise. This is real patient-centered nephrology. Is this backed by evidence? Definitely. This is from a meta-analysis that looked at 22 studies on the subject. The evidence is appropriately stage sensitive. For stage 1 and 2 CKD, patients are generally safe. For stage 3, you want to be a little more circumspect, caution, monitor and individualize. Stage 4 and 5 should trigger more caution and probably avoid. The outcomes for renal outcomes are a little more mixed, as they should be when you are studying a heterogeneous CKD population in a dry fasting state. But the message is that renal function is often stable for stages 1 to 3. Blood pressure may improve, and not every CKD patient who fasts deteriorates by default. This directly challenges the simplistic idea that CKD patients should not fast. Any resemblance to my opponent here without the French beard is purely coincidental. What I'm trying to say is that we are comfortable prescribing methods for allowing patients to fast during Ramadan. Of late, every one of us is very happy to talk about GLP-1 receptor agonists and extol upon the benefits of Ozempic and Mounjaro for appetite restriction, less calorie intake, and weight loss. But if we talk about intermittent fasting, all of a sudden our tone changes. When in effect, all of this is about less eating and calorie restriction. So this is my preemptive rebuttal slide. This was a study which, when it came out, created a lot of media buzz. The ENHANCE analysis showed that an eating window less than 8 hours was associated with increased cardiovascular mortality, but we need to be a little disciplined when we interpret this data. This was an observational study. This was not a randomized controlled trial. Bias was built in because they used limited recall, which is not equal to a sustained time-restricted eating, which was well implemented. And there is residual confounding, as well as the fact that this was a general population study, not directed at DKD, CKD patients. So while this data is cause for concern, it should not be sensationalized. It does not outweigh the overwhelming RCT evidence which shows benefit in terms of metabolic benefits for patients with diabetes. These will be the objections I expect that my opponent will bring out, that the evidence is heterogeneous. I would say that the evidence, while heterogeneous, includes multiple study designs, and the RCT data converges towards benefit. Hypoglycemia risk is too high. That is a supervision problem. It is not a reason to dismiss the intervention. If he says that there is no hard kidney endpoints, I would argue that the absence of hard endpoints does not mean equal to harm. And there is enough intermediate outcome evidence to say that this is still a useful intervention. And fasting is too dangerous for CKD patients. We know from our Ramadan example that that is not true, and it is not evidence-based. So not everybody needs to be on intermittent fasting. There are obviously candidates who you would say should not be on it. I would avoid it in advanced CKD or unstable kidney function, those with recurrent hypoglycemia, complex insulin regimes, frailty and malnourished patients, pregnancy and recent history of diabetic ketoacidosis. I would also be a little more careful to prescribe it in hot conditions, in those who have a heavy diuretic regimen, acute illness, planned long fasting periods, and unstable BP or multiple comorbidities. But this is personalized lifestyle medicine, not a mass prescription for fasting. The more vulnerable our patients, the more conservative we must be. Saying that some patients should not fast does not weaken my argument, it strengthens it, because I am saying that the reason we are restricting it for some patients is clinical and evidence-based. In the interest of time, I will conclude. The burden of proof has shifted. IF is an umbrella, not a fad, and there are multiple patterns of IF that we can offer to our patients. For diabetes, the evidence clearly supports benefit in glycemic control. For DKD, even if the hard clinical endpoints are still not definitive, there is intermittent outcomes which are beneficial. And the Ramadan example shows that nephrologists know how to operationalize safety in fasting. And therefore, the question is not whether IF is a friend or foe, it is definitely a friend, but whether we can implement it safely, selectively, and intelligently. So let us all not be like the orange man and dismissively ban fasting. The aim should be to try and personalize and monitor our patients who have DKD or CKD. Thank you.
A very good morning. In fact, now it's good afternoon. First and foremost, thanks to all the organizers for giving me an opportunity to speak against intermittent fasting. I know I am swimming against the tide. I am the villain in the house, but still I tried to do my maximum. And sorry, apologies, my slide crashed. So that is another reason for me swimming against the slide. So I had to prepare my slide here, sitting here. So apologies for that. One cannot think well, eat well, or sleep well if one has not dined well. Virginia Woolf. Food is not just eating energy. It's an experience. It's a primitive form of comfort. I'm in Hyderabad today. Sanjeev Nair, sir, for a biryani? Yes or no? Okay. So maybe ban maska or Irani chai after this debate. But will you refuse saying that this is not in your fasting window? Then why have we even come to Hyderabad? So, intermittent fasting is modern day obsession. I think everyone here has their own views about intermittent fasting. So, as sir has already shown, you switch on the TV, there are so many anchors, sportsperson, and celebrities talking about intermittent fasting. Forget all of them. Go back to your homes. My wife is a rich gynecologist, and I am an average middle-class nephrologist who's a foodie by heart. So, I don't want time and my obsession to decide what should I eat and when should I eat. Probably it is not what should you eat. It is definitely when you should eat. Intermittent fasting is a broad term where fasting and eating alternates. In that, time-restricted feeding is a specific popular type where there is a consistent window of 4 hours. So you should remember here, it is less of diet, more of when to eat. It doesn't strictly tell you what to eat, but rather when to eat. Definitely, it's a weight management gimmick. So there are now why am I against intermittent fasting? Dr. Sanjeev Nair has given so much evidence. We already have this evidence. We fast during Ekadashi, Sankashti, Navratri. Ramzan, of course, there is Rosa. And also Jains, they don't eat after the sun sets. Now here I am talking about intermittent fasting in diabetic population and in chronic kidney disease population. Do we have all the data here still? No, I don't think so. So it is just a wellness darling and a pure marketing gimmick. Now let's go to diabetes per se. All the observed data are just because of the observational data, very less RCTs, which have definite endpoints about what will be happen to CKD or what will happen to diabetes. So going with diabetes, now let's assume India, so many diabetic population. So how frequently does a diabetic come to your clinic? How many diabetes patients do you have? Can you ever titrate their medication because that patient is trying some fancy treatment of intermittent fasting? It is not possible. Can you monitor his hourly glucose levels? Can you monitor using a continuous glucose monitoring? He will have hypoglycemia. So don't go with intermittent fasting for all diabetics. Next, so we have death in bed. As sir quoted, there's an evidence. I also have an evidence from American Heart Association conference in 2024, where 20,000 people who had 8-hour restricted feeding periods, in that 91% there was an increase in cardiovascular death rates. So I don't think at present intermittent fasting can help us with all the diabetic population. It is not one size fits for all. Coming to the other part of it. Now, what you do is you restrict the feeding to few hours. What happens? That patient, during that feeding hour, he tends to overeat. So what happens? There is hyperglycemia. So you are trying to solve the problem, or are you increasing the problem? At the same time, the patient might not consume specific amount of nutrients that is prescribed during that window, or he might overeat. So this is definitely a very tricky situation for all physicians. Apart from this, there can be euglycemic ketoacidosis, especially in patients using SGLT. Archives of Endocrinology, Metabolism and Critical Care journals have multiple articles where they say that it's a life-threatening emergency that intermittent fasting significantly predisposes to euglycemic ketoacidosis. We all, as physicians, have dealt with dawn phenomenon. So now what happens to dawn phenomenon? Here the sugar increases. So in intermittent fasting, there is an increased level of sugars because patient tries to overcompensate, and as sir has told, the physiology also contributes to it. So we need not have to do any of these gimmicks. We just have to follow what is basic. What about dehydration? Has anybody defined specifically in a particular diabetic patient what exactly is that intermittent fasting? No. It can be different for different patients and supervised differently by different physicians. So because of this, there can be dehydration. The patient can go for dehydration. Next, during the feeding window, the patient might consume lot of water and go for volume overload, which can stress the cardiovascular system, and second, cause hypertension, again cause damage to the kidney. This is a study as per Dr. Sribhushan Raju and et al. In around 2014, where the healthy volunteers itself drinking lot of water, there was increase in the blood pressure, and it was statistically significant. Now what about sarcopenia? Our patients are already malnourished, and you tell them you don't eat this for this period of time. Are our patients so educated, so sophisticated? No, definitely not. So they will definitely try to either undereat or overeat. So this will contribute to the sarcopenia. As sir also said, disordered eating, definitely. When you tell them don't eat this in this particular window, eat in this particular window, definitely they will continue that psychological habit of not eating, which might contribute to the problem. Now what about intermittent fasting in chronic diseases, chronic kidney diseases? Intermittent fasting is not recommended. Again, lack of multiple RCTs. As sir quoted about a Ramadan article, so I would also quote one by Malik et al. In Clinical Kidney Journal 2021. Most of them are observational studies, very less RCTs with a specific endpoint. An article by Hu Yu et al. In Preventive Medicine Reports 2025, where 11 cycles of NHANES examination survey from 1999 to 2020 showed that there was loss of, during the shorter windows, the risk of progression of CKD increased. Next, now what happens during the feeding window in these chronic kidney disease patients? They eat a lot of things. Because of this, there is again variation in the electrolyte imbalance. They tend to have a lot of juices, sweeteners, fruits and all. So there can be life-threatening hyperkalemia and cardiac issues. At the same time, when intermittent fasting happens, there is shift of potassium, and that also can cause hyperkalemia as well as other electrolyte imbalances. Now again, the pharmacological conflict. How many of your CKD patients are only on 1 or 2 medications? Are they? They are on multiple medications like ACE inhibitors, ARBs, SGLT2 inhibitors, then also on diuretics. So as the patient changes, is it practically possible to monitor each of those patients and adjust these medications? No, I don't think it is absolutely not possible to tailor make each and everyone's medications to adjust the progress in GFR. Then another thing here, during the feeding window, what they do is they eat a lot of protein to compensate for not eating the nutrients during the fasting window. So there can be increase in the protein spike and also disturb the filtration in the kidney. Next is hyperglycemic variability. Because of the increase in the sugar spikes, this can already damage the vascular endothelium in a patient who is at stress for CKD. Continuing this again, muscle wasting and sarcopenias. It is already a pro-inflammatory conditions restricting the feeding pattern. The patients might not consume the protein and lead to muscle wastings and sarcopenia. Now what exactly happens in this intermittent fasting is, we try to process the insulin, we tap the fat stores, and so ketone productions. So excess of ketone productions can cause acid-base disturbance. So all this have some amount of scientific background and scientific support. But what we exactly have to decide is, are we ready for this? Do we really have patients who can stick to intermittent fasting in a way that is prescribed by Dr. Sanjeev Nair? There's ifs and buts. Do we really have resources to go ahead with intermittent fasting? This is direct heart-to-heart talk according to what we face every day in our clinical practice. So, for diabetes, slow and steady doesn't win the race. Slow and steady avoids emergency admissions, avoids trouble to the patients. In kidney, in CKD, it is about preserving what is that which remains. It is not about stressing what is left. So do not test the limits of the failing system. I know I am swimming against the tide, but I still firmly stand for against intermittent fasting, specifically in patients with diabetes and chronic kidney disease. Thank you.
An excellent rebuttal, sir. We need to have a rebuttal on this. Yeah, you go ahead. Yeah, sure.
How much time do I have? 1 minute. Okay. So I want to make a couple of points. I want to thank Dr. Naik for effectively making my point for me again. I want to say that if we decide to go now after this for Hyderabadi biryani, bun maska and Irani chai, that is about 3,000 to 3,500 kilocalories. If you do that for one meal, you are effectively left with nothing else to eat because most of our basal metabolic rate is about average 1,500 to 2,000 kilocalories. So if that is the way we want to eat and that is the way we are going to tell our patients to eat, I'm sorry, we will cut a very sorry figure. If you are going to say during the fasting period, your patients are going to drink juices and eat fruits because they are, during the eating period, they are going to drink juices and eat fruits because they are having a very limited eating window, I don't think we've done a very good job of educating our patients. So what I have been saying is effectively what Dr. Naik has also said. This is not a blanket prescription for everybody. There are patients where you want to avoid it, but in those patients where it works, it needs to be prescribed with care, with monitoring and with supervision. Our refusal to take the time to do that does not mean we should not offer it. Thank you.
Want to defend?
Thank you, Sanjeev sir. Again, you have made my point very clear. You had in your first slide told it's a family of intervention. Yes, when we can't manage a single individual, how can we manage a family of interventions with multiple interventions, multiple advisors? Do we really have the time and resource? That is one. Second one is Ramzan point. I have already given you the evidence where it is the other way also. It can worsen CKD, it can create problems for the patients, it can create problems for the doctors. Fasting physiology, you told it is extended physiology. When physiology becomes extreme, it becomes pathology, sir. It no longer remains a physiology. Next, alien people, making it alien. No, I am talking about what exactly we, an average Indian physician and an average Indian doctor has to do. So let's not talk about alien. When evidence is there, it is approved by ADA and KDIGO, and made it simpler for us to practice. We will go ahead with this. And yes, exactly, you again made my point, comfort level. It is definitely not in my comfort level and also not my patient's comfort level. Thank you.
So it's the role of the chairpersons to bring a truce between the two. And I think the right phenotype, I think it's the renal phenotype where we rightly want to use this combination of therapy. When, why, and how is the option to slow and steadily decreasing the renal outcomes. You want to say something?
I'm more biased towards intermittent fasting, but I have one doubt, sir. That is, let's say if you are not giving any fluids in the phase where he's not going to get, can you advise them to go ahead for slightly bicarbonate-rich fluids to tide over the acidosis which is going to increase?
I was saying yes, we can, but except in the case of Ramadan, there is no need for fluid restriction in these patients. We are actually saying that they can take fluid. Obviously, in CKD, we'll have to be a little more worried, but in just diabetes, you're not worried at all.
At the same time, can we advise them to go ahead for slightly electrolyte-rich fluids?
Sure, again, in diabetes, not in CKD.
And intermittent fasting, is it always better to go for early intermittent fasting or the late one?
Yeah, so this is where the enhanced data becomes a little more useful. I would think that it is better to have, and that's what the data also shows, it's better to have an early eating window and a later fasting window.
Okay.
I congratulate both speakers, but the naked fact in Tamil Nadu is that only 6% of the diabetic population has sugar control. This was given to me by the Public Service Commission of Tamil Nadu, and only 8.5% has who are on treatment, hypertension control.
I just want to make a comment, sir. It was good debate. I actually support Nagraj sir regarding intermittent fasting. As we see, no sir, I just want to make point. As we see, like in Ekadasi or Sankashti fasting, after whole day fasting, we eat sabudana, which is very high calorie than the regular rice or chapati. So the calorie intake, the glycemic up and downs will be huge difference will be there. And then for prasad we eat Shrikand, again so much glucose controls. I think for Indians, our cultural this thing, whenever we are in fasting, we tend to compensate with more calorie rich diet, which leads to more glycemic variations. I think first we have to change our dietary cultural this thing before stressing on fasting.
Because Ganesh, we just had a previous session where everybody spoke about increasing protein in diet.
Yes, sir.
I think if you use your eating window
Yes.
to increase protein and decrease carbs, you should be fine.
That is what we have to stress the patients.
Yeah, audience.
Yeah, we want to have the audience poll. How many wants to go with Sanjeev?
Ma'am, not an audience poll, please. I know I am going to lose flat.
No, it could be a surprise. It could be even surprise that you can win.
So who is with Dr. Sanjeev? I'll have to be neutral. So, Nagraj, you know the answer. Thank you so much.
I have a comment that most of the studies which were done for the intermittent fasting used subjects control. They in the control arm they did a 3-time eating window.
Sorry to interrupt. I think people are enjoying the debate, but because of the want of time, this can be taken at later during the lunch hour. So I request to proceed with the next session. Thank you.